areas. The first one is ineffective or incomplete care. What I heard was by the time the patients referred to me, they're in such a state that hospitalization is unavoidable. Another subspecialist told me there just aren't enough of us in my specialty to handle all the patients who need us. So the waiting time to see me could easily be 6 months. And by that time, they may be back in the hospital. So hard to argue with these points of view. The question is, what can you offer the subspecialist in the way of a role to try to deal with these two problems? One of them I was involved with was a behavioral health integration project where we wanted to do a better job of screening for depression. What we found is that the hard part isn't screening for depression. The hard part is doing something about it at the primary care level, because many primary care physicians don't feel comfortable handling some of these problems. So on the back of the screening form, we put together, with the help of the subspecialists, some guidance about what to do when, how to advance care if the first attempt doesn't work, how to deal with side effects. This turned out to be extremely popular among the primary care community, and it actually greatly expanded their competence. More to the point, the psychiatrists functioning as subspecialists here were really pleased to see that they didn't have to take care of those problems anymore. They had more time on their schedule for those people who otherwise might have to be admitted and readmitted while they're waiting for psychiatric care. So this is a very successful intervention, and it was an intervention among primary care doctors, but it was spearheaded by subspecialists. We have an endocrinologist in our region who decided to kind of flip the ratio between support staff and nursing staff and doctors. So instead of having 5 endocrinologists and 1 diabetes educator, they had 3 diabetes educators for every endocrinologist. And they used those educators to work with patients in the community with primary care teams. And they were able to remarkably reduce per capita referrals and hospitalizations, saving a great deal of money, and also allowing the endocrinologist to be available for the more complex patients. So again, this is something that particularly is going to make more sense as we get into accountable care, where if you can give care much more, if you can avoid all those hospitalizations, you're going to save a lot of money, and somebody is going to be willing to pay for that kind of care. So this is a real-life experience that's been going on in Western Pennsylvania now for over 15 years. There's a very exciting approach to virtual education called the ECHO Project, or Project ECHO. And you can see on this slide all the different issues that they are now working with. They started with hepatitis C. They wanted to make sure that hepatitis C therapy, once effective therapy came available, could reach all the people in rural New Mexico. And so they set up a virtual case conference every week where you could meet with a group of specialists in various areas to help you apply the new information about taking care of that problem. And now they've spread that throughout the nation and among 20 different topics. So this is like having a consultant in your backyard. And we're going to see more and more of this. Subspecialists are key to making these work, because we need their wisdom and experience to share it with those of us in primary care, so we can apply it on the front lines.
Quick question. Someone in the chat asked about, these sort of curbside consults and what sort of programs were available. And so this sounds like this gets at that. But the follow-up question is, how are specialists and primary care physicians compensated for these kinds of services that are a little different? And I don't know if you're going to speak to that, but.
Well, I can give one example. We had done a behavioral health integration project with people at ICSI and 7 other partners around the country. The work that we did between psychiatrists and primary care, there are now behavioral health integration codes that pay the psychiatrist staff, pay the primary care staff to be working together to take care of patients with behavioral health disorders. Some of the continuity of care codes can be helpful there as well. Once you get into an accountable care organization and you start to work with bundled payments, then the business case becomes very attractive, because you're using an endocrinologist to take care of 20 complex, moderately complex patients in 2 hours. He would normally see maybe 4 of them. So you can really begin to take advantage of these skills in a very efficient way.
Great, that's very helpful. Thanks.